Hello, good evening. Welcome to a beautiful sunny evening in South Manchester. Well, that's where I am, or just outside Cheshire, actually, technically. Wherever you are, guys, welcome. Really nice to see you all. It's been a busy day at the practice, and I've actually been really looking forward to this. I couldn't wait to get out just to get home and get involved with this. So welcome. I hope you guys have had a good day. Don't know where you're coming from. Maybe send some messages over to us to let us know where you're coming from. This evening we're going to be doing some MSK. I hope that's what you signed up for, and you didn't sign up for the diabetes one, and now you're a bit shocked and thinking, what is he talking about? What am I going to sit through? So, bit of an introduction. Who am I? Haven't met me before. My name's Duncan. I'm a GP. I work in South Manchester, but I live just outside in Cheshire, which I'm 2 days a week. I'm still a GP partner. I still like it. Yeah, it's busy. It's pretty full on at the minute, isn't it? But I do like that. The rest of the time, I do education, MD medical. I also work with medical skills courses, joint injections, that kind of thing. And basically, when I'm not doing that, I just try to run away from it all, including my 2 young children, 4 and 6 year olds, who keep me busy. So whenever I get the chance, I just run away from everything. Helps keep me sane, gives me balance, actually keeps me healthy. And we'll come into that later. So if you have any questions, that's my email as well. You can fly those over at a later date. But it's not just me tonight. I'm joined with Andy, who you may well have met already, another fellow GP. In fact, I'll just let him introduce himself. So I'm going to fly over now to Leicester and say, hello, Andy, are you there?
Hi, Duncan. Yeah, hello, everyone. I'm here in Leicester, as Duncan said. The sun's shining beautifully out here just now, and I've even had a bit of a barbecue this evening. That's how I'm rolling at the moment. I'm also a GP, as Duncan said. I work in inclusion healthcare, so I work with homeless and asylum seekers in the city centre here. And I work at Leicester Medical School, where I'm teaching medical students in the early years of the course, and I teach them MSK examination as part of that. So it's really interesting for me to realise how much of that I've been doing wrong when looking at Duncan's presentation. When I'm not working, I do like riding my bike a lot. I tend to ride off-road as much as possible, so I do tend to fall off on a fairly regular basis. So I'm frequently discovering new MSK conditions through my own personal experience. Tonight I'm the Q&A person. That means I'm here in the background. If you've got any comments, any suggestions, anything you want clarifying, just put them in the Q&A box. I'm going to post a little question in there now so you can see how it works. And I will try my best to answer them. There's a lot of you here tonight. I've only got 2 hands. I'll try to answer as many of them as possible. If you post the question, you don't get an answer, feel free to email me after the course and I'll reply to that later on. I'll be happy to do that. Duncan's got a lot to get through, so I'm going to hand back to him now. So, just mention, everything's anonymous. Anything you post, we won't attach your name to it. If you're one of those people who hates putting the hand up in a big lecture theatre, now's your opportunity. Stick it in there in the Q&A. I won't tell anyone it was you that posted the question. There is no such thing as a stupid question here. So fire away, and I'll speak to you later on.
Thanks, Andy. Yeah, brilliant. And please do keep Andy busy. You know, he's been warming up his hands all day. He's sitting around having a barbecue, isn't he? So now need to work those fingers. That's one of the great things of this format is, you know, you can be totally interactive all the time. Don't need to wait for the breaks to do that. And everyone looks around at you as you put your hand up. The other benefit is you can now sit back, relax, maybe even have a glass of wine, something exciting. You know, it's not breakfast time now. You don't have to hide it in a mug. You can actually embrace it properly in a glass. So first off, why do we need this webinar? You know, we get so much information, don't we? We get, you know, all these updates, all this information about the latest evidence and guidance. And that's sort of really precisely why, you know, we're busy enough at the moment. I can't remember the last time that during the day I've opened a journal. So you don't get the chance to do that. So the idea is we've sifted through that for you and bringing hopefully the most up-to-date evidence for you to enjoy. And that's the first and most important rule for tonight, is to just relax, enjoy, soak it up, and hopefully learn something. There's a whole realm of resources I'll be going through during this course, and we've put them all together in a one-page document you can download. You've hopefully found it in the resource tabs, that green one. They're all linked in there so you can find them later. We based this around some clinical cases, as you'll see. Hopefully makes it more relevant. We've already said how interactive this is, so yeah, do fire them over to Andy. And those are our emails. So if we don't get around to your question, please feel free to get up in touch with us afterwards. And then lastly, everything we talk about is just our own, we found this ourselves, we've dug through this, and there's no influence here from outside or anyone else at all. So this is a picture of Andy falling off his bike. Actually, no, it's not, don't worry. Just to show, we're going to starting off with shoulder pain. Before we do, though, I'd be just interested from yourselves of what you find difficult in your practice. What's the most common MSK issue? So I suppose from that, we're saying, what thing do you see maybe the most of, but also maybe struggle with the most? It's just useful maybe to get thoughts about what we might cover at another time, but just get an insight. We're probably all in this together, as David Cameron once said, and well, it doesn't feel like it so much now, does it? And just think just to see where the problems maybe lie. That'd be really useful. I imagine back pain is probably going to be the top hitter, as was always the case, because it's just constantly there and constantly a problem. So we might just ignore back pain. Yeah, that's looking pretty popular. And next up, let's have a look. Next up, shoulder pain. Well, brilliant. You're in the right place. So let's just straight into then shoulder pain. Okay, so as you just highlighted, it's a big problem. We see a lot of this in primary care, and potentially 14% of the population will struggle with some form of shoulder problem during their life. At the moment, it feels like probably more than 2.5 per GP consultations. Feels like a lot more of that we're seeing at MSK, but particularly shoulder problems at the moment, whether that's a relation to our working pattern. Generally, you can divide shoulder problems then into two forms, very generally. Traumatic, as you can see here, dislocations, fractures, that kind of thing. Primarily, that's going to be A&E, maybe urgent care if that's where you work. But the bread and butter, really, what we'll be seeing is more the atraumatic types like frozen shoulder, osteoarthritis, rotator cuff issues, impingement syndrome, all that, bursitis, all the like there. Difficulty sometimes is trying to sift through that. Which one is it that's sitting in front of us? What is the problem? And therefore, how do we manage it? It's a bit like trying to pin the tail on the donkey sometimes. And I'm sure we're just all a bit guilty sometimes of just referring to physio with shoulder pain, hoping they'll do the work for us. So the idea tonight is we're going to try and simplify this so that maybe we can try and manage this a bit more and get a bit more satisfaction out of managing some of these problems. So first up, got a case, is Maggie. She's 52 and she's got slow onset left-sided shoulder pain. She's right-handed, so she's managing, but the pain is becoming pretty troublesome, particularly when she's trying to get dressed in the morning and sometimes at night. She's been to the urgent care doctor on a particularly bad day when the pain was so bad, and he told her she's got arthritis, and she's come to see us about that because she's never been diagnosed with it before. So you see Maggie, based on that history, what do you think's going on? Has she indeed got osteoarthritis, or has she got other things like supraspinatus, tendinopathy, adhesive capsulitis, or frozen shoulder? Has she got impingement, subacromial bursitis, biceps tendinitis, or rotator cuff tear? What do you think is going on with Maggie? Please fire over your thoughts. I mean, normally we say there is no right answer. Obviously, there is a right answer, but we're not going to hold you up to that. I would just be interested to where your thoughts are based on Maggie's presentation just so far. You know, we do a lot of online consulting, telephone consulting. We don't often get a full picture. Sometimes we have to guess a diagnosis without even examining a patient. Okay, I think we've got enough in there. Thanks, guys. Brilliant. So you've all planned for, about 50% of you anyway, for adhesive capsulitis, or frozen shoulder. So 50% of you, well done. Yes, you're right. That's what we're talking here. The type of patient probably, hopefully, would have influenced you, as we'll see in a moment. So what is frozen shoulder? Well, the shoulder, just like most of our big joints, has a big capsule around the joint itself. So anything within that inflammation causes some thickening, some adhesions, and basically the capsule becomes a sticky balloon around that and restricts some of those movements, particularly the rotational movements. Yes, this can be after trauma or some form of injury, but quite often this is with no primary cause at all. It just happens. There are some things to look out for. Who gets it first? Who gets it first and foremost? Who's the most commonly person to see this? Well, really, this is going to be typically the middle-aged female. It's more common in females than men. It's common around the 50 to 65 year age. It's also more common in people with diabetes. there is potentially a family history or genetic component here, so it's worth delving into that a little bit. And if they come in and say they've had it before, most commonly this is in the opposite shoulder. It's actually quite rare to get a recurrence in the same shoulder. Not quite sure why, but that's so. If they are getting it again, it may make you think twice about that's what's going on. So we are deciding we're going to see this patient face to face. I know, shock horror. We're going to see someone face to face. So what are we going to do? What do we need to look for in examination? So as you'll find, probably most of her movements are restricted, but certainly in the early stages, that may just be limited to the rotational movements. And particularly internal rotation. The problem with that is it's quite difficult to assess internal rotation because the body gets in the way. So we focus here on external rotation, shown here in this picture. Patient is essentially doing what is down in that bottom picture. They're fixing their elbows to their torso and they're rotating out their arms just from their shoulder. This is showing you here a limited bit of external rotation on the left side compared to the right. But it's important that we need to do active and passive movements here, because if you just let the patient to do it, what's the passive movements, and don't do the passive movements, then this could just be because it's painful and she doesn't want to move it any further. So we need to check there's a fixed endpoint. Sometimes that's difficult because they're guarded. And if there's one thing that's going to stop a patient relaxing, it's us saying, relax, and then relax, and then we get angry, relax, and then everyone's a bit tense. So actually using some form of distraction is quite helpful here. A physio taught me once, which I think is a really nice technique. In this position, patients in that position, you're trying to get them to do some external rotation and then try and get them to extend, but hold their hands so it's resisted extension. Get them to push, get them to really get into that and focus on the pushing. And then tell them to relax, stop pushing. And as they do that, try and do some external rotation. They're still thinking, or the brain's still thinking about the extension as you rotate them out. You can get a bit more movement that way. But if they've got limited, there's a fixed endpoint to that external rotation, that is frozen shoulder. So once you've made that diagnosis, what's really important is we give that patient some information so they can understand what to expect. Now, this is a self-limiting condition. If you do nothing with it, it will get better with time. But time is the problem. It can take a long time. Each of these phases can vary hugely. The first phase alone can come on either quite quickly or slowly over a month and can last up to 9 months potentially. This is often the worst phase for patients because this is where the pain comes. So they're getting some stiffness, but it's painful and uncomfortable. This is often when they present. After the freezing phase and the frozen part, it's stiffness, but the pain should have settled. So they're then left with restrictions. And then after that, it starts to free up. But again, very slowly. And this can take potentially up to 3 years. So it's important that patients understand that. Otherwise, they'll be back banging on the door saying this isn't getting any better. What about imaging here? Any use? Well, no, not really. As you've seen here, the history normally is quite specific and the examinations are really useful to pinpoint this. If they've got good external rotation, it's very unlikely to be frozen shoulder. So really, imaging is only useful if you're thinking this is a bit weird and wonderful and I'm not sure what's going on, or they're just not responding as you would normally expect. So based on this point, who of you are going to say, right, frozen shoulder, what can we do? Or who's going to say, right, I can refer to physio with a diagnosis? Who's going to refer and who's going to treat? I wonder if I've clicked a bit too soon there. Oh dear. Okay, food for thought there, guys. Would you referred or would you have... I won't get you to send that over to Andy because he'll suddenly get 400 yes or no's. She won't be very grateful for. He's shaking his head at me. So, okay, it would have been interesting to know what you would have done there, because actually, if we send to physio, they're not going to do much more than we do. They're going to see them, they're going to explain what the condition is, and they're just going to give them some exercises to do. So actually, this is very much something we can manage in practice. And I think with longer waiting times, particularly for physio, too much gin and coffee, sorry. So with longer waiting times, potentially 8 weeks before you see a physio, if you're struggling with pain and restriction, that's a long time to wait. And if all they're going to do is something we could have done, I think we've got a role to play here. So some really helpful resources. There's loads. I've tried to sift through and bring them down to some more specific ones, but feel free to have a look through the list. Pick ones that you like, that you want to work with, and just use that. I have a list now on my desktop, and I just copy and paste the URLs to the patient of the ones that I want for each condition. I know the leaflet, I can explain it to them. So this is a really helpful one from Oxford University Hospitals. It explains the condition, what to expect. It's got exercises in. It's really helpful. Another one that is brilliant, a very fantastic resource if you haven't seen already, anything shoulder related, British Elbow and Shoulder Society. One positive to come out of the pandemic, because there are some positives, is we now have a wealth of resources, and a lot of them were driven by not being able to see a physio. And this is exactly what they did. They basically took a physio consultation and put it online. So they have a range of videos, including introduction videos explaining what to expect from the physiotherapy, how long this will take. It's brilliant. So I highly recommend having a look at that resource. And I've got one on frozen shoulder. There's other videos. So I mentioned medical skills courses. They've got some YouTube-based therapy videos, quite simple, 30 seconds long. So you can pick some of those, send them to the patients, and they can just watch them online. So hopefully you found that useful. Hopefully you now feel empowered to manage frozen shoulder, because I think actually once you've made the diagnosis, it's quite straightforward. Like most of these things, I'm afraid it's over to the patient. The physio is not going to do the physiotherapy for them, and neither are we. They just need to go and do it themselves. So just the information, what they call cognitive rich therapy. Essentially, that means offloading it to the patient. Okay, next up, we've got Michael. So Michael's 50. He's got shoulder pain that he's had for 3 months. He's keen on his DIY, and he's decided he's going to renovate his house, and he's decided to have a bit of a tidy up. But like most of us, he just can't bring himself to get rid of all this stuff, so he just shoved it in the loft. But unfortunately, while he was doing that, he injured his shoulder, and he's now left with some pain at his shoulder. Dig into sort of what his background is. He used to work on a construction site. He's now more of a consultant role and has been sat at a desk for the last 12 months. But he's really struggling to lift his arm without pain. He can move it okay, but it's really quite restrictive. We get him in, we see him, because we're feeling in a good mood. That's 2 patients you've seen today. And when we move him, we find actually he's got a pretty good range of motion, but he's got pain in certain of those motions, which he's quite uncomfortable, but he's just brave and gets through it. Particularly, he struggles with extension and abduction. So over to you guys. We're going to click this time. Same old list, but a different problem. Which one is it? Which one are you going to choose from here? I'll let you guys run with this for a little bit. I'll give you a clue. He doesn't have frozen shoulder as well, because that wouldn't be a very interesting talk if we just did that twice. Okay. I'm hoping there's going to be a bit of more of a range here, a bit more of a selection, which is what's looking like. Brilliant. Thanks, guys. Yes. Exactly what we're looking for. Okay, maybe one latecomer who's gone for frozen shoulder. So yeah, as I said, we're not doing frozen shoulder again. You'd be glad to hear. So he hasn't got frozen shoulder. But yes, good spread is exactly what I was hoping for. So we've got a spread between rotator cuff problems, impingement, subacromial bursitis, supraspinatus tendinopathy. So which one is it? Bottom line is, it doesn't matter. Okay, so the terminology here has changed really to reflect our understanding of the pathology, but also what the therapy and what the treatment is here. So the new terminology here is rotator cuff related shoulder pain. Just rolls off the tongue, doesn't it? RCRSP. Really, this is an umbrella terminology, a bit like non-specific lower back pain. And the idea here is that we're trying to group these conditions together, because actually making that pinpoint diagnosis doesn't matter. They're just going to get the same treatment. They're going to get the same therapy. The strengthening and the exercises around the shoulder are going to be the same for all these conditions. So now it reflects all of those things: rotator cuff tendinopathy, rotator cuff tears, subacromial pain syndrome, impingement, bursitis has now just become a lot simpler. It's a very common problem, probably the most common shoulder, probably about 70% of shoulder pain that we see in primary care is this, and one of those conditions under that umbrella terminology. Yes, it can happen from acute trauma, overarm throwing, javelin throwers, football goalkeepers, if you get loads of those. But probably far more commonly, this is going to be a slow attritional process over time. Hence why it's more common in the sort of over 60s age group, because they just had that longer level of attrition. So just looking at that disease spectrum of sort of the umbrella terminology and how it encompasses. So initially they just get a bit of pressure, a bit of irritation. The tendon swells, gets a bit more compressed within that impingement, that subacromial gap because of the swelling of the tendon. Then it gets there's a few parts of that tendon that break down and essentially die. That's what tendinopathy is. So you're left with a slightly weaker tendon that then gets irritated again, maybe inflamed. Sometimes calcification will come in there and you might see that on a scan. It doesn't matter. It's not that relevant. They then could progress to tears, minor tears, or even full thickness tears. Again, that doesn't matter too much. We're managing that spectrum rather than those individual parts of it. So one really useful point here to consider is what you've got is a swollen tendon that's sitting in a fixed space in that subacromial pace underneath that bit of bone that shows in the top picture there. So anything that closes that gap is going to increase the pressure and the pain. One thing that really does that, we sat at our desk first thing in the morning, let's go, 60 odd prescriptions to do, you're feeling ready for it. But by lunchtime or even late afternoon, you're slumping forward in your desk, you're not up for it. And just in that slumping forward, you put your shoulders into internal rotation and you compress that gap. So changing that posture, getting the patient to sit back, open their shoulders up. For a lot of people, and that can be really a real big change from their pain. It can take a lot of pressure off and make them much more comfortable. Unsurprisingly, this is the second biggest, most common problem in taxi drivers after back pain, just because that's what they do all day. Okay, so what's relevant in the history? What are we looking for? How it comes on, that can be really useful. Is this sudden? Is it more of an insidious? Particularly if it's a young patient. If you've got sudden onset in a young patient, that's a different group. They need different management. But probably more useful is looking into the background. Why does that happen? Have they become a bit deconditioned because they're a bit more sedentary, a bit like this patient here? Spend more time sitting, more time wearing that shoulder tendon. What do they want to get from this? Again, really important because that will guide our management. Do they just want to be able to sit comfortably and work? Do they want to get back to doing some more vigorous activities? Things that will help manage their pain is thinking about what causes their pain, so getting a bit of history. I can't do this particular activity. I can't throw the javelin in a minute. Well, but they might be able to swim or cycle or something like that. Something that will at least give them some respite while they're getting back to the activity they want will make them a much happier patient. And then lastly, what sort of tests? Well, typically in medical school, we'd have learned about the painful arc. The problem with the painful arc is it's painful, and therefore patients often can't do the full arc where you're looking for that free of pain when you get to the 10, 15 degrees at the top. They can't get that far because it's just too uncomfortable. So another test you could do, empty can test. That's what's shown at the top here. You're essentially getting them to turn their hand, and get the camera here, from that position to that position. And in doing that, you're putting the internal rotation and you're packing in the shoulder. Very simple test. The other thing you can do, resisted abduction shown in that bottom picture. Do they get pain when they're doing that? That's pretty diagnostic. What are we going to do then? How are we going to manage this? First off, reason they've come in, it's uncomfortable. And if we want them to get to do their therapy properly, we're going to need to manage that pain. Just remember here that non-steroidals can be a very effective pain relief, but they're not treatments. You can't have 2 weeks of non-steroidals to get this better. That's not going to work. It's just pain relief. Find out what those problems are, those problem activities, see how we can tweak them to make them comfortable, but at least get them to do something. But generally better than do nothing. If they do nothing with that shoulder, they rest it, it's going to stiffen up and it's just going to flare up as soon as they use it again. What about refer? Physiotherapy. So do we refer them or just offer them physiotherapy? What they're going to be doing, if we do see a physio, they're just going to be doing very much what we are, looking at their posture, how can we correct that? What are their problems? How can we correct that? And then give them some exercises. And the key here is progressive loading. So whatever they do, they just need to progress it. So doing the same thing for 8 months, they're going to reach a low threshold. So when they get to a point where it's working, then they move it forward. That's what the physios do. We can do that with a lot of leaflets here. What about an injection? How's that useful? Is that useful? That's what often patients come to us and say, can I have an injection? My shoulder hurts. I've had it before. It worked. Brilliant. So how good are injections for rotator cuff related shoulder pain? Cochrane did a review of this back in 2003, I know, a long time ago. And they said that actually not great evidence to guide this here. It might work, but we haven't really got a lot of evidence to guide us. Most of it's anecdotal. There was some more research back 2013, did the same sort of thing, meta-analysis. They found pretty much the same. Not much had changed. We were happy doing something, so why research it? What they generally found is that, yes, it seemed to work quite well for maybe 8 to 12 weeks, and then didn't work very well after that. And there's certainly no benefit from multiple. What they did highlight is you need appropriate training gear, because the risk is if you inject into the tendon, you can make the problem worse and create more damage. So you might want to be image guided, yes, but certainly you want training to do this. And do remember, this is only pain relief, so they do need to have therapy alongside this. What about surgery? Any good? Well, unless you're a young patient with sudden onset and you want to get back to some vigorous activity, javelin thrower, then actually surgery is not going to help you. Surgery for them, yes, if that's the case, we need to refer those patients early. That's pretty rare in what we see, isn't it? Far more, it's going to be the chronic, slow, middle-aged patients with the chronic problems, and they don't need surgery. Because actually, what we've learned from surgery is essentially it's been really good evidence to show us that it just doesn't work. So just a bit of an overview of all the different treatments that have been tried: resewing the tendon, repairing tears, shaving off the acromion to make the space bigger. What we found, actually, they're no more effective than physical therapy. And in some cases, physiotherapy is better, certainly less painful and has better recoveries. What about imaging? Is that any use? Again, not routinely, no. If you x-ray an over 60-year-old, you're going to see arthritis. Is it arthritis they're presenting with? Well, we've already seen here in this case, no, it's not. So actually it's going to muddy the waters rather than clear the waters. Just remember, always clinically correlate the findings on the x-ray. You might get it from a colleague. They're sending you their shoulder pain because you're now the shoulder guru, and they come to you with an x-ray, and you've got to debunk some of that imaging before you can actually get into the problem. So really only for fractures, or if you think something weird and wonderful is going on. Ultrasound, very easy for us to get, isn't it? So we often reach for that, particularly if we're consulting someone online. I get an ultrasound and I'll see you. But actually, that can be quite user dependent, and not necessarily adds anything more than a quick examination anyway. Really, the gold standard here is MR scans, but often these need to be kinetic, i.e. moving MR scans, nothing we can get here. I think the bottom line, really, from an imaging perspective, if you're thinking you really need imaging to help you out, it's probably you need someone else to maybe have a look at this. But yeah, ultrasound is recommended in the guidance, mostly because it's so freely available. Really interesting here, a study, they scanned a group of patients who were over 60, no pain, no problems at all, but scanned their shoulders to see what they found. 30% of these patients had some form of rotator cuff tear with no symptoms. So just be wary, if you image them, we might find stuff that just doesn't matter. So what about resources? Again, loads to pick from. I've tried to highlight some of the few of the better ones. There's some really good leaflets from BMJ and Versus Arthritis, but there's some nice videos again from medical schools courses. But this is my personal go-to favourite, British Elbow and Shoulder Society. Again, they've got this wealth of videos. They've got it specifically for subacromial pain or rotator cuff related shoulder pain. That's what they've got. Including an introduction video, which is great, just a few minutes long, tells them exactly what they're going to get from physio. So again, this comes back to that question. GP, physio, who do we need to manage this? And there's been a fantastic trial published last year looking at best practice physio, what helps these patients. So in this group, they were essentially put into one or two groups. Either you would just get one-off physio appointment. It was about half an hour long, but you got a long physio appointment, essentially talking through the condition and best practice, versus 6 or up to 6 progressive physio appointments. They saw you, they worked through the exercises. They sort of then monitor these patients, look for outcomes for 12 months, which ones are better. They had a subgroup where half of those patients were given a steroid injection before the physiotherapy and half weren't. They essentially created 4 groups. When they looked at this for 12 months, there was no difference between any of the groups at all. The only difference was at 8 weeks, they found that the joint injection group in both of those subgroups was a little bit better. But after 8 weeks, no difference whatsoever. Really interesting here that one-off physio appointment, giving them information and some exercises, was just as good as seeing that physio over 6 different occasions. So actually, we can manage this quite happily ourselves, particularly now we've got such good resources like that British Elbow and Shoulder Society. Send them the link, off they go. Okay, last up, we've got our third shoulder patient. We've got Judy, 72. She's got pain in her right shoulder, previous right total hip replacement. Hopefully, I think this one's going to be quite straightforward for you. Certainly now we've got through the difficult ones, the more complicated shoulder problems, although I'm hoping they now seem a bit easier for you. So what's going on here? Has she got one of the rotator cuff problems? Has she got some adhesive capsulitis? Or has she got osteoarthritis? Let's see what you think. Yeah, I think you've all got it. Brilliant. Somebody still loves frozen shoulder. I love the fact that we're just going to get 3 cases of frozen shoulder. Okay, so just a quick reminder here from osteoarthritis, because actually there's a bit that's changed in the last few years, and that's really around the terminology and how we talk to our patients about osteoarthritis. Because what they want us to do is get away from some of the negative terminology like wear and tear and indeed arthritis, because actually what that does to the patients is often make them a bit more guarded, and they protect, and they don't use those joints, they don't exercise as much, which is exactly what they don't want to be doing. They want to exercise, they want to strengthen these joints. That's what's going to help manage the problem. So what is this? Really, this is where, with aging, with change, some of the joints change slightly. It starts off with just some roughening of the cartilage, and then the body starts with these repair processes to try and help manage that joint. So there's a bit of effusion, that stretches the capsule, you get a bit of laxity. The joint laxity itself then causes some of those problems. And then you know that can wax and wane and come on differently over time. So what we want this patient to do is use that joint, strengthen it up, and keep some of that laxity at bay. Primarily, this is going to be the glenohumeral joint, but don't forget that small AC joint at the front. How do we disseminate that? That's really simple. If the pain is there of your AC joint, it's AC joint arthritis. So you can do scarf tests, which sort of compress the joint and compress that AC joint if you want to. But really, if they're saying the pain is all over here, it's glenohumeral. If it's here, it's AC joint. That's what this article in BMJ is highlighting for us. So how are we going to manage this? Fantastic resource here. You're probably familiar with it already. Got rebranded a few years ago from Arthritis UK to Versus Arthritis. It's got a fantastic resource for everything arthritis. But yes, it's got some exercises they can do, but essentially it also answers all those questions they're going to give us. Can I exercise with this? How much exercise can I do? What happens if my joint flares? What do I need to do to rest? All of those questions answered for you. So I just signpost any new diagnosis to this website first off. Pain relief, yeah, that's going to be fundamental here, and they may benefit from injections as part of that. Really important here is weight management. We know that osteoarthritic weight-bearing joints, not so much the shoulder, but the other big weight-bearing joints, benefit massively from weight loss. A 15-kilogram weight loss can halve their symptoms. So importantly, when they get this diagnosis and they're in pain, to reinforce they keep active to try and stop gaining weight, because that's just going to add to their symptoms. Okay, any shoulder hacks? It's always a big question, isn't it? Is there a simple way to manage shoulder pain? Actually, there is. There's this really useful leaflet being generated by the Nuffield Shoulder Clinic. So if we just work through this a little bit, this is on the NICE guidance, but I've sent you the link because it's a bit easier to find than sifting through it to download it. What is it? Essentially, it's just a few-step process to work through. So start off, take out your red flags. Hopefully that's straightforward. I'm not going to go into that now. Next up, neck pain. Is it neck or is it shoulder? Because very commonly, shoulder comes from the neck. So we get them essentially to move their neck in normal planes. Does that reproduce the pain in your shoulder? And you'll be surprised how often they say yes, in which case it's neck, or at least the muscles joining the neck to the shoulder, like your our neck and shoulder muscles. AC joint, very simple. Palpate around the AC joint. Is it tender? That's the core. And does that reproduce their pain? Then we're into the shoulder joint proper. So we're looking at external rotation, as we've already demonstrated. Is that a fixed endpoint compared to an active and passive movement? Yes, it's frozen shoulder. What about painful arc? Well, we talked about that. Yes, you could do the painful arc test, or you could just do some resisted abduction, or that empty can test where you turn your hand to fix the shoulder and compress the space within the shoulder joint. So that is a really quick algorithm. It takes about 2 minutes at best to work through with patients. It's a really simple way of working through some of those, and then you can drill on into it a little bit more if you need to. So quick summary here, frozen shoulder, absolutely we can do this. We don't need to refer this, certainly for the majority of cases. Rotator cuff related shoulder pain, that new umbrella term, I think it simplifies the majority of what we need, 70% of our shoulder pain problems. Remember, that best resource is brilliant, and often that means they don't even need to see a physio, but it takes time. All tendon irritation takes time. Lastly, osteoarthritis, just think about how we describe those to patients, our terminology, and versus arthritis. Fantastic. Okay, let's pop over to Andy, see what you thought of that, see if there's any burning questions.
Thanks, Duncan. Yes, and loads of questions. I'm going repetitive strain injury here in my fingers. My shoulders are beginning to ache quite a bit. Quite a few questions. I want someone asking about COVID and joint injections, because obviously we were cautioned against injecting joints during COVID. I've put a link up for a really good leaflet from the Oxford University Hospitals on steroid injections during COVID. I think perhaps after watching this presentation, you're perhaps not so keen to inject so often. It has less of a place than perhaps you may have thought before. So hopefully you might not be doing so many injections as you were once thinking of doing anyway. I think after Duncan's talk here. Interesting question, Duncan. I don't know if you answered to this one really. Do diabetics with adhesive capsulitis need referring to secondary care because they're not likely to get better? Do you know if there's a difference between the progression in diabetics with adhesive capsulitis compared to non-diabetics?
Okay, suggestion. So no, I'm not aware of any evidence that they don't get better. The difficulty with all this is compliance. So it's more down to how they comply to their therapy. And I suppose I'm not flagging up diabetics as poorly compliant to treatment, but essentially if they don't, then that's what's going to influence them getting better or not, rather than the diabetic.
Sure. Thank you. And some questions. A question about sinister cause of referred pain, having to consider those as a cause of shoulder pain. I think it's coming back to your basics that you did at medical school. The history is all important. Are there red flags? Is this a patient with a previous history of cancer, maybe with weight loss, systemic features? Night pain is concerning, so someone who's not able to sleep at night because of pain may raise a red flag in your mind, so that would be something to think about. Certainly we should be considering those sinister causes in patients in the right age groups, I would say. And question about analgesia in pregnancy for MSK problems. Great question. I think paracetamol obviously safe to use in pregnancy, but actually keeping movement, ice packs, all the things that we're recommending for patients who aren't pregnant would apply in pregnancy. And I think there's lots of evidence that keeping active in pregnancy can help with MSK issues, not specifically the shoulder there, I guess. Loads of questions. I'm going to let you get on, Duncan, because I know you've got quite a lot to get through. I'll carry on trying to answer as many of these as I can. Really glad that from my role in medical. Yeah, over to you.
No, that's great. Thank you, Andy. And yeah, thanks guys for keeping him busy. Just on analgesics, Andy's, he's highlighted a really important point there, but pain relief doesn't just have to be tablets. Yeah. Ice packs can be really helpful, certainly after long periods of loading. And the other thing that really helps is actually loading exercises can really help. So isometrics, they're really simple exercises, but they can be really good to actually offset a lot of pain. So getting and doing some exercise, like you said. Okay. Speaking of exercise, or lack of it, next topic, beware of the chair. Is sitting the new smoking? So just a bit of background to this. Inactivity, you may be aware of this, but has been linked to pretty much everything. It's the one true anti-panacea, if you like, activity being the one true panacea. And unfortunately, we spend quite a lot of time being inactive. On average, 7 to 10 hours a day. You might agree sometimes that's longer than that, certainly when you're a duty doctor. And when you look at the stats, we're not, the adolescents are really struggling with this. This is quite specific guidance, but 80% of the world's population of adolescents are not compliant with or are insufficiently physically active. That's a worrying stat for what's coming down the line. And to take on a positive note, just 10 minutes a day of moderate intensity exercise, that can add 2 years to your life. That's a really big motivator, I think, anyway. Is this new? Well, actually, no. If you look back in the 1950s, they found that bus conductors were living longer than bus drivers, probably because they were inactive, the bus drivers. They'd solved that problem, though, don't worry. They just got rid of the bus conductors. So let's meet our next case. I was trying to think about who to pick from this, who sits around long periods of the day, who's become more inactive, who spends a lot of time sitting at a desk, who is a bit more grumpy than usual. And, for anyone, you could pick anyone from primary care, couldn't you? But I plumped with a GP. So we've got Mark. He's a doctor. He's a GP. He's actually had type 1 hypertension for the last 6 years. He's very keen to avoid medications. He's fully aware of all the side effects and just doesn't want it and is trying to manage it himself. But his latest reading, it's gone up a bit. Previously, background, he was a keen runner, used to run a lot of 10Ks, then he got a knee injury, doesn't run anymore, and that's been a downward spiral since. He's become more and more sedentary, particularly through the pandemic, and he's now developed some lower back aching and some right-sided shoulder pain. All too familiar, isn't it? So based on that, brings up some questions. Does he now need medications? Is there a way we can continue to help Mark to avoid those medications? What are we going to do about what is obviously causing him some problems, that sedentary activity and that posture? So just a bit of insight to what inactivity can mean. It's listed, as I say, to pretty much everything, but these are the top 5, including some forms of cancer and heart disease. When you look at this world map, the dark pictures are the worst places. And right sitting there, right in the middle of that nice thick dark patch is the UK. So we are one of the most inactive, or would stand to gain the most by becoming active. What's it do? Reduces insulin sensitivity, slows down the metabolism. Weight gain is linked to some of the hormone problems, including some of the hormone cancers like breast and colon. And of course, it leads to deconditioning and all the problems that encompasses too. So just a bit of a food for thought here. We can quite often spend a whole consultation sometimes discussing hypertension, the risks of that, and a blood pressure medication like amlodipine and its side effects. But how often would you spend maybe even half or even 2 minutes of a consultation actually talking properly about inactivity and looking into that? But when you look at it, as your bang for a buck, you're probably going to get a lot more for that. And as we've already said, that's not just cardiovascular disease you'll be influencing. When you look at cardiovascular disease specifically and the risks of the effect of inactivity on all those risk factors, blue here is bad, that's relatively inactive. Brown is the active. And you can see all those risk factors reduced by just being a bit more active. So just a reflection on yourselves and what might stop you doing that, or having a bit more of a proper consultation about activity, inactivity, lifestyle, if you like. I don't really like that term very much, but what would stop you doing that as maybe part of the treatment in a consultation? Have we just got enough time? I've already dealt with 4 problems. I'm 2 hours behind and it's my 3rd patient, so maybe I haven't got time for that. I don't really think how significant this is. It's not real medicine. I can actually do more with the time than talk about that. My patients don't buy it, so I'd probably be wasting time. I don't really believe in it enough. I know we should probably mention it, but it's not something I really buy into. Okay, let's see what you guys think. And pretty much everyone, I think that's fair enough, isn't it? We don't have enough time. But interesting, some of you are thinking, my patients don't buy it, so I'll be wasting my time, or my patients won't really take on what I'm saying, I suppose is what we're saying there. And that's really interesting. Thank you, guys. That's a perfect segue. Thank you. Almost rehearsed that. So this was an article back in 2019, primarily looking at GPs. But what they did do is also interview the patients about activity. What they found actually during the time, which probably reflects a lot of what we do now, about 70% of GPs weren't talking in depth about inactivity. We were mentioning it, but more of a throwaway comment, partly because we didn't buy into it, and it was all talking about how we sell it. What they did find, though, that 1 in 4 patients would be more active if they were advised to be so by their GPs. And more importantly, 70% of patients would become more active if their physician was more active. So we need to see ourselves as these powerful role models that we actually are. We have a big influence on our patients just by being and doing what we say. But also, more importantly, just looking after ourselves. This is a good reason. There's a win-win here, isn't it? We look after ourselves, we're going to help our patients. So in this article, they highlighted, and remember, this is 2019, how increasing demands, increasing pressures on GPs, increasing stress, well-being struggling, long desk hours. That was 3 years ago. It's even worse now. So even more reason, if we haven't addressed this, we should do that. How could we do that, though? I'm so busy. I'm so stuck at work. What am I going to do to try and break that down? Well, we've got a few ideas just to sort of try and take on. I know it's difficult and I know it's really busy, but this really needs to be that opportunity to just change this a little bit. So one sort of, this is based around the idea of trying to stop or limit your inactivity to 30 minutes or no more. So maybe when we have our catch-up slot, what do you do in your catch-up slot? Well, obviously, apart from catching up, what do you do in your catch-up slot? Do you then think, when that pops up, that's going to be the chance I'm going to do some sort of activity. I'm going to walk to reception and take that pile of scripts I've just signed. Am I going to go and take all those pathology pots I've labelled and drop those up at reception, go to the toilet? If you're like me and you've had a cup of coffee at 8 o'clock, I'm going to the toilet every 20, 30 minutes anyway, so I've solved my problem. I'm going to go up and run up the stairs. Am I just going to do sit to stand for a minute? See how many times you can sit to stand in 1 minute. This is really an opportunity to try and do something a bit more active and try and make yourself a bit more active. Go make a cup of tea. That's another double bonus. One thing you could do, which is really we've embraced in our practice, and it's been quite eye-opening how much people have enjoyed this. So a sit to stand sort of desk adapter. I've got one in the minute, so I'm standing here dancing around at my desk, a bit like the one on the right, one on the left at work. It's great. I spend the majority of my time now standing. Not that standing in itself is a great form. It's still fairly inactive if that's what you do, but it allows you to move and be active and move around the room. I think it's been brilliant, and my colleagues have really taken this on too. You could, as you can see here from this, it will change your posture too. So just by standing up, I'll go from this position, slump forward, to a much more open shoulder position, as is demonstrated here in this photo at the bottom. You can even start doing some yoga at the desk if you like to, if you really want to take this to the next level. The world is your oyster. But essentially, a standing desk allows you to do more movement, allows you to be more active. So it's a really simple solution. What about mental health? We all know that mental health potentially is better by activity. Is that really the case? Well, there was a study back in the Lancet in 2018 in looking at over 18s in the US, and they basically looked at self-reported bad days and then looked at how much exercise they did. What did they find? Actually quite dramatic. Doing exercise reduced their bad days by 43% over those that did no exercise. All types of exercise were a winner. That was fine. They all worked. It didn't really matter what. But they did find that there were slightly better results, unsurprisingly, in those that involved a bit more camaraderie, so team sports, going to a gym, being a bit more social. That gave them the better bang for their buck. So essentially, just being more active is going to now include our cardiovascular health and includes our mental health. So going back to Mark and that idea of, is there something we can do just before we start to reach for that prescription pad and give him some medications? Well, actually, this was a really fascinating review in the BJSM in 2019, looking at exercise versus our sort of more commonly used antihypertensives and its effect on blood pressure. And this is showing you in this forest plot here that actually they're fairly similar. And that's sort of what they found. Although there was no head-to-head direct trials, they did find that exercise could be pretty much comparable in most patients to most commonly used medications. Yes, medications probably were slightly more effective at the top end, but actually overall it could be very effective in a properly used way. So they concluded from this meta-analysis that the systolic lowering blood pressures of aerobic exercise, and ideally when this combined aerobic and strengthening exercise together, they got a much better effect than one of those alone. But actually it didn't really matter too much which exercise it was. they could have a similar effect to antihypertensives. So definitely worth trying that first. But that's not just going away and just being a bit more active. That's thinking about actually doing some exercise, maybe an exercise class, giving them maybe an exercise prescription, something to do instead. So how much is enough when we're talking about exercise? WHO have some guidance here. You've probably heard of this. Adults, 150 minutes a week, ideally, and that should be spread, if we can, across the week. So that's 30 minutes a day is one of the targets they mentioned. They suggest that's a minimum, and ideally you should be aiming for maybe nearer 300 to get the even better effect. We should also be doing some strengthening twice a week. So as we get older, unfortunately, one of the big problems we get is we get weaker, and that often leads to a lot of the joint problems and the aches and the pains that we get. So strengthening, and that doesn't mean you have to go bodybuilding or lift something heavy. That could just be body weight exercises, squats, lunges, HIIT classes, do some Joe Wicks, that kind of thing. That will really help, and you'll notice that some of those aches and pains fade away. Over 65, the same, but maybe bringing in some balance to that too, to avoid those falls risks. This is the interesting one. In 5 to 18-year-olds, they switch between moderate to vigorous exercise here, and they should be saying an hour's vigorous exercise 3 times a week. I think that's quite a big ask, isn't it? And that's probably unsurprisingly why 80% of the population are not hitting that. But there's good reason for that, because they need to be doing that more to give them that benefit through their life. What's the difference here between moderate and vigorous? So very simply, moderate, if you're running, you can talk but you can't sing, then that'd be moderate. I tried that this morning. I was probably leaning into vigorous because I definitely couldn't sing, which most people are very happy about. But when you're talking, you can't finish that sentence, then you're into that vigorous range of exercise. So it doesn't have to be really, really hard to be able to reach that vigorous zone. There's some advice here for pregnancy and postpartum as well, which is quite helpful to give to patients. There is some useful advice from under 5s as well. We won't get into that too much detail, but essentially if patients want to know more, parents need help, the NHS website is really helpful in giving them some ideas and tips to get their toddlers a little bit more active. So how are we doing? Not great. 50% females, third of men, and we said 80% adolescents are not reaching these targets. It's getting worse. We're more sedentary. One question often people ask is, what about offsetting? What if I went for a 60-minute run and some of that was vigorous? Would that then mean that I could sit all day without a problem? And this was looked at in the Lancet back in 2016. And what they found, if you did 60 to 75 minutes of moderate activity a day, you could then sit guilt-free for 4 hours. But as you've already said, unfortunately, we are sitting for a lot longer than that. And the majority of the population do not do an hour and 15 minutes exercise a day. So yes, in theory, but in practice, that doesn't often stand up. So we do need to think more about breaking up that inactivity. What about if we don't reach those goals? What if we're doing less? Or if it's just 15 minutes a week, will we still get some benefit? So this was a big study published in the Lancet in looking at Taiwanese populations, and they split the population into inactive, medium, low, and high activity group. They then looked at they compared the mortality risk of each of these groups compared to the inactive group. What they found was even in the low group, the low activity group, who were on average doing 92 minutes a week, so that's less than 50 minutes a day, they still achieved a 14% relative risk reduction in all-cause mortality and a 3-year longer life expectancy. So that's dramatic, really. And the bottom line here, which is reflected in the WHO guidance, is essentially any activity is going to give you some benefit. Anything is good, but absolutely more is better. So what about resources? We decided we're going to have a chat with our patients about this. What can we use to try and help us and help them? So one interesting website here is called Start Standing, and it talks about how you might be able to incorporate a bit more activity into your day. I like some of these. One is have a smaller glass of water rather than the big bottles that we often trend towards now. So a small glass of water on your desk means you have to go and fill it up more. So then you have to get up and move. Putting your desk further away from the bin, so you then have to walk to the bin. Obviously avoiding travelators and lifts where possible. As we said before, strong coffee or a lot of caffeine, brilliant. You just need to wee all day. That will keep you active. Absolutely stop your buzzer, because we used to go and collect our patients, don't we? But we're not doing that so much because we're doing so much more telephone consulting. So do we have a way of trying to get us out of that chair a bit more? Moving medicine, I'm going to come to this in a minute. I think this is a really helpful resource. Another one, the RCGP have a active practice initiative. If you haven't seen this already, practice can sign up for it, but they've got a wealth of resources, different types of resources that you could tailor to your patient in front of you. Park run, 5Ks, all sorts of ideas you could pick through to see if there's one that works for them. But the bottom line here is trying to move or break down inactivity to less than 30 minutes. What about an exercise prescription? BJSM, the BMJ Open and Sports Exercise Medicine looked exactly at this. They found that actually we're not very good at it, unsurprisingly. It's quite difficult. It's quite difficult to get our patients to buy in. And they suggested what seems a bit simplistic, but an ABC approach. It's probably what we would do anyway, delve into what they think of activity and how much they do, look at what their barriers are, and then think about, how you might guide them into doing a bit more. But one thing I think was really important, which we probably don't do enough of, and I was a bit guilty of, is follow them up. If we start them on the antihypertensive, we're going to see them again. We're going to see the effect of that tablet, aren't we? So why don't we necessarily do that with exercise? And then we can encourage them, and it gives them a goal. I'm going to see my GP again about this. He's going to call me about this. Right, I better get on and do something. So moving medicine, if you haven't seen this website, I think it's brilliant. It's a really helpful resource designed to get healthcare professionals and trying to integrate physical activity into the conversation a bit more. How does it work? Just walk you through it quite quickly. So you can tailor this to conditions. It doesn't matter too much, but you could pick a condition to make it a bit more personalised to that patient. So for Mark, we're going to go for some primary prevention of cardiovascular disease. You can then pick how much time you're going to spend. You might say, I just got 1 minute, I'm going to make myself a cup of tea, so I'm just going to spend 1 minute on this and then I can get rid of Mark. Or you might say, right, I'm going to go for it. I'm an hour ahead of schedule. I'm just going to go for it and spend 10 minutes or more. It will then give you a load of prompts to start that conversation, some open questions to get that going, to delve into, to focus around physical activity. It then generates a patient info section and what you could call a prescription, but some guidance for that patient, some steps for them to take away and go and do and build into their day. So in a sense, generating a bit of an exercise prescription for them. They could either have it to download, they could print it out if they really want to. There's even a QR code for those really tech savvy. And then lastly, just to highlight really, sitting is the new smoking. Is it? Or actually, no, it's not sitting so much, it's inactivity. So even if you were to stand and stand still, that's inactivity. We need to keep moving. And there's a nice little video from someone called the Prehab Guys. There's some American online videos, physios, who talk exactly about this and show you maybe some things you could be doing at your desk to just get a bit more active. So popping back to Mark, remember in his hypertension, what could we do? Well, we could actually talk to Mark about an exercise prescription. He may, then we can try and maybe avoid those medications for a little bit longer. We can now talk to him about how he can break up his sedentary periods at work, how he can maybe change his posture to help with his lower back pain and his shoulder pain without having to start on endless medications. So briefly, in summary, the bottom line here is let's become a bit more active and a bit less sedentary, because we are doing the opposite at the moment. We're becoming less active, more sedentary, with the wholesale negative effects of that. Activity, exercise, it's one and the same. So we don't need to get bogged down in talking about exercise. Just being active is going to have some benefit, as we've seen. Let's just delve into a little bit more. Let's look at why they're not more active. What can we do to help them break down that barrier? And then lastly, if I was to say to you, I've got this magic tablet here, it will reduce cardiovascular disease, blood pressure, diabetes, cancer, joint pains, improve your mood, improve cognition, lose weight. And has it got any side effects? Yes, it has. It will give you more energy and make you feel good. We'd probably prescribe it, wouldn't we? So maybe we should think about that a little bit more. Hopefully you found that, guys, useful. And he's been busy. His fingers keep going into glasses of water to keep cool. But let's pop over to see what you thought. Oh, Andy, you're on silent. Andy, I think you need to turn your mic on. Sorry.
Yeah. Can you hear me now? Yeah.
Yeah, it's great. Thank you.
It's the Zoom generation. Yeah, loads of people talking about things they've done, cycling to work, GPs, role modelling, 15-minute appointments. Someone talks about how that can really help when you're going to move into a lifestyle conversation. And certainly I would agree with that. And it's sort of, I don't know, it feels like a bit of a luxury, doesn't it, 15 minutes? But the moving medicine allows you, as Duncan said, to set a time limit on how long you're going to have that conversation with the patient. And that's quite an interesting approach. Never seen anything like that in the resource. An e-bike as an option for people. People talking about patients with disabilities or chronic long-term conditions which might make movement difficult. And I think it's just having that conversation, just trying to make it the patient's decision to do that and let them choose the activities that they can do rather than trying to impose an exercise regime on these patients, particularly if they have disabilities, for instance, because any sort of movement, even if it's just moving your arms around, can be helpful for these patients. But really interesting it's changed the way I thought about my desk. I've been certainly standing up a lot more, moving around a lot more, going up and down the stairs a bit more at work if I can do that. But I think we're just about out of time, Duncan, aren't we? So I'm going to hand back to you to wrap up.
Okay. Thank you. Yeah, thanks, Andy. And yeah, great. Thank you, guys. Really positive to hear all the things you're doing. I agree, being active work, cycling to your home visit, it's brilliant. Patients are so excited when they suddenly see you with your helmet. It's brilliant, particularly if you're drenched in water and rain and I think they come in, have a cup of tea. Oh, I'm fine. Don't worry about me. You know. Someone's highlighting here about cold water swimming. Is that any benefit? Yeah, there's some good benefit here. Cold water swimming from a mental health perspective. Big push, isn't there? Wim Hof has really taken that on. Get a bit Hof. Okay, anyway, thank you, guys. It's a bit of a whistle-stop tour through all that. I hope you found it useful. Hopefully the shoulder's a bit more simplistic now. We've got our new talk coming up soon. Sarah's going to take you through some new evidence and guidance in diabetes. So if you want to sign up for that, if you haven't already, that's on Tuesday the 5th. That'd be great. I'll be there too. It'd be brilliant. And then lastly, if you can, bit of feedback when this closes down, you'll get some prompts to do some feedback. It's really helpful to us. It guides what we do. It guides how we do it too. So please do feed that back to us. That'd be great. But most importantly, guys, have a lovely evening. Enjoy yourselves and please look after yourselves and be more active. Thanks.